I'm Sarah Norcross, and I'm the Director of Progress Educational Trust, which is an independent charity which aims to improve choices for people affected by infertility and genetic conditions. The theme of tonight's webinar, IVF a test case, whether and how clinics should test patients and staff for COVID-19. Just as viruses evolve, so too do rules, guidance, and the tests that guard against viruses. And during the coronavirus COVID-19 pandemic, we've been given, I'd heaven offend I'd be giving anyone advice, we've been given changing advice as to where we can go, whom we can see, how far apart we must be from one another, and when and where we should cover our faces. How does this relate to IVF? So after fertility treatment was suspended earlier this year, the resumption of fertility services remains challenging as we all adapt to live with COVID-19. Helpfully, the Association of Reproductive and Clinical Scientists and the British Fertility Society produced best practice guidelines for the reintroduction of routine fertility treatment. And the first of the key principles that underpin these guidelines is resumption of fertility services must take place in a manner that minimises the chance of spread of COVID-19 infection to patients and fertility clinic staff. Now, I fear, like most things, this is easier said than done. However, clinics have started doing this. So how should clinics go about achieving this now that they're open? In particular, how and when should clinics test staff and patients for COVID-19? So tonight we're really fortunate. We're going to hear from two experts, Professor Jason Kasraie, and then we'll hear from Ippokratis Sarris. So Jason is the chair of the Association of Clinical and Reproductive Scientists, that's ARCS. He's head of fertility services and consultant embryologist and the person responsible to the HFEA at the Shropshire and Mid Wales Fertility Centre. And he's a visiting professor at the University Centre of Shrewsbury and the University of Chester.
Thank you, Sarah, and thank you for the kind invitation to speak tonight. So I think if we're going to talk about testing of patients during the COVID crisis, we really need to look at the guideline which Sarah has given us a very good introduction to. So the guideline itself, the latest version is version 2, was published in June of this year. Version 3 is pending. We're having a meeting of the expert group in August to look at version 3. But I have to pay tribute really to my co-authors on this. I was privileged to work with a group of people who were very much willing to work under pressure, because this was a very big task done at relatively short notice, and a lot of people burned the midnight oil on this. So, tribute to my co-authors on this particular guideline, and it's fair to say that we were representing the views really of the executive committees of both the BFS and of ARCS as well. So we have 5 key principles that the guideline is based upon, and Sarah's introduced one of those, which is the resumption of fertility services must take place in a manner that minimises the chances of spread of COVID-19 infection to patients and staff. So that one clearly relates to testing of patients and staff as well. Second one is that centres should ensure a fair and transparent approach to any prioritisation policy. We wanted to be certain that, because we were aware that patients would be delayed, etc., during treatment, we wanted to be certain that those who had been delayed for the longest and were the most needy got the opportunity to be treated first. We then have another one that relates really to testing as well, which is resumption of treatment should not result in undue burden on the NHS. And one could argue that if we're increasing the spread of COVID-19, we are increasing the burden on the NHS. Patients considering treatment should be fully informed about the effect of the ongoing pandemic on their treatment. I have to admit that's quite difficult because we still have a lot of uncertainties, and I'll talk a little bit more about that later. But we're certainly trying to give patients the information that we have available to ourselves at the moment. And then the fertility sector should adopt sustainable changes in working practices that help to build resilience against any future increases in the spread of COVID-19. Now, resilience is key to what we're trying to do here, because I was personally involved, sadly, in the recommendation to close the sector and to close clinics that came from the BFS and ARCs, and that's something that we don't want to have to do again. And so it's all about building resilience, and testing plays an important role in that, potentially. So before starting treatment, what do the guidelines say you should do? Well, they say you should have a screening questionnaire and antigen test if that's available. They say that patients and donors with a diagnosis of COVID-19 infection should not start treatment until they've recovered and are not considered infectious. And that centres should consider whether they advise patients and potential donors to self-isolate if possible from the start of ovarian stimulation until egg collection. So in my particular centre, we screen patients on the day of their baseline scan, and that's a swab. We have a questionnaire a triage questionnaire that they fill in at every single appointment, and we actually phone them up, and that's filled in over the phone. So they wait in the car park, they don't come into the department until that's done. And then we screen them again 2 to 3 days before they have their egg collection procedure as well. So during treatment, as I said, we have a coronavirus screening questionnaire that we have, and that's recommended in the guideline as well. Patients, donors with negative coronavirus antigen tests at the start of treatment and who remain negative on questionnaire screening should be allowed to complete the treatment, says the guideline, which seems reasonable. You know, if you're negative, why shouldn't you continue to be treated? And in centres that institute an antigen testing policy, consideration should be given to a further test just prior to treatment. Now, in my case, I work in an NHS centre. In our trust, all of our day case procedures and operative procedures, we have to screen the patients before they come into the department anyway, or come into the trust anyway. So that's not really a choice that we have. So the guideline goes on to talk about the actions in the event of suspected COVID-19. So if a patient or donor develops symptoms suggestive of coronavirus or screens positive on the questionnaire during treatment, an antigen screen should be arranged and treatment should not proceed unless the patient screens negative. Now, obviously, there's a relatively high false negative rate actually with the antigen screening. The swab that's being used at the moment, we'll talk a bit more about that later. But that's what the guideline says, we should be screening by swab. In the event of a patient or donor presenting with suspected or confirmed COVID-19 after the ovulatory trigger, a multidisciplinary individual risk assessment should take place to balance the risks of refraining from oocyte retrieval with those of proceeding. Now, you might think that it's a really easy decision to make, actually not to go ahead with the treatment if somebody tests COVID positive, but there might be some cases where you need to go ahead with the treatment. And one I can envisage here is that if a patient had oncology treatment and was preserving their fertility or seeking to preserve their fertility, they might have a very limited time span. You might need to go ahead and store some eggs or embryos, and this might be the last chance. You know, you might not be able to delay treatment in order to do that. Now, we know that if we use proper PPE and we take proper precautions, then the risks of cross-infection to ourselves are very low. But to be fair, there aren't many instances where we would consider going ahead with treatment, which is why we put in this multidisciplinary risk assessment. But like I say, there are some cases where you may have to go ahead or feel like you have to go ahead. And we also said that at present there's little data on the risk of minor surgical procedures in women with a diagnosis of COVID-19. And patients who become symptomatic after egg collection, provided there's no risk as I just described, should be advised to freeze all their embryos for future use. So, what does the guidelines say about staff? And we actually, in the UK, say quite a lot about staff, and I'll talk about the international guidelines later. But we say that essentially staff information means that centres should ensure staff are given timely information before the resumption of treatment. Now, the majority of centres are already resuming treatment or about to resume treatment, but it really put the onus on the centre to set expectations from the staff regarding adaptations within the clinic and the treatment pathways, etc. And we also talk about staff conduct. Now, in my own department, we have our staff sign up to a code of conduct in the same way that we have our patients sign up to a code of conduct with regard to COVID. And that code of conduct means that they will be duly diligent in applying social distancing rules for themselves and their family, etc. So that's all about maintaining a responsibility or understanding a responsibility to minimize the spread of COVID-19 and to follow government guidance. And that can be quite difficult when government guidance is changing quite regularly, because the situation is changing quite rapidly. It's quite a dynamic situation. Towards the end of March, beginning of April, it really felt like the ground was moving under our feet every second. So we've also put the onus on staff, though, to ask them to maintain an up-to-date knowledge and adhere to government guidelines and clinic policies. So there's an emphasis on the centre telling the staff, giving the staff information, but also the staff being receptive and willing to learn. In terms of staff testing, if you work in the NHS as I do, you will probably have had an antibody test by now, I would hope. I had mine a couple of weeks ago. Now, I personally was ill around the end of March. I had to self-isolate, and my antibody test came back negative. I wasn't that ill. I had kind of mild flu-like symptoms. Somebody else who worked in my department who was really very ill around about the same time has come back as being antibody positive. In my own trust, 15% of the staff, they've nearly all been tested now, have come back positive. And what was really interesting was that those who were considered the highest risk, those who were working in the COVID hot areas, who'd obviously been paying special attention to PPE, etc., they had the lower rate of infection. So if you took them as a group, it was about 10% versus 15% of the rest of the trust. And what that suggests, I think as we accept relatively widely now, is that most of the transmission in hospitals is actually happening outside of the hot COVID areas. It's happening in the staff rooms and where staff are mingling, etc. So, what are others doing? Well, if you look at the ESHRE guideline, ESHRE suggests a staff triage before you restart treatment to see whether or not staff have developed symptoms, etc. Now, while we don't actually state that in the UK guideline, it's pretty much clear from the guideline that you should do that. We just don't emphasize it. They also go on to say that staff suspected of infection after triage should undergo regular SARS-CoV-2 IgM and IgG testing. Now, I'm not an immunologist, but I suspect that antibodies are produced several days after you're actually infected, and probably several days after you're actually infectious yourself. So I'm not entirely sure if I'm misinterpreting that guideline there, but that is what the guideline says. They then go on to say that staff who are symptomatic should be referred for medical advice and testing and should not re-attend until they've tested negative by the standard kind of PCR throat nasopharyngeal swab test. So they're mixing the antibody testing and the PCR testing, or the antigen testing as it's commonly referred to, which is an interesting approach. In the UK, our guideline doesn't mention antibody testing because at the time the last guideline was written, there was no widely accepted, properly validated antibody test in the UK. And also, as I said earlier, the antibody test will tell you whether you've been infected rather than whether you're actually infected and infectious at this moment in time. So, talking about patients, ESHRE talk about triage of patients in the same way that we do in our guideline. And then they also go on again to talk about antibody testing of patients. So suspected infection after triage should get regular antibody testing. I do wonder whether that means just to test whether somebody was actually infected or not, and whether the implication is that they would already have had a swab test, an antigen test. And they also say that all patients with previous confirmed COVID-19 infection should present medical evidence of clearance in order to be eligible for treatment. They don't state precisely what that medical evidence of clearance is. And if you look at the literature, sparse as it is, it would appear that, you know, it's difficult to establish absolute clearance. Even in countries where they've done 2 swab tests a few days apart, they've found that some patients who've been discharged actually then a week or 2 later have a positive swab. Now, whether or not they're still infectious, we don't know. But you know, with the false negative rates being as high as they are for the PCR testing, it's possible that somebody that you would think was negative would still be positive for the virus. So the ASRM take a slightly more similar approach to us. So they suggest a baseline PCR test at around about the time of starting treatment and prior to any surgical intervention. And they also state that it would be prudent to encourage patients who test negative to self-quarantine throughout the course. So that's a bit like that code of conduct that we talk about our patients signing up to. It's, you know, saying that you will not expose yourself to any risk of COVID-19 infection during your treatment. In terms of staff, they don't really talk too much about staff testing, but they suggest that incorporating staff testing in your management strategies when staff testing is available would be a prudent thing to do as well. And that was from update 4 of their guideline. So I think if we're talking about the UK approach, I'm really looking forward to seeing what Ippo has to say on this. You know, I guess one criticism of the UK approach could be, are we being overly cautious by asking for too much testing? You know, and I think what I would say there is that we're still in a situation where we have a lot more questions than answers, and we have to remember that even 8 to 10 weeks ago, we were in a completely different situation. You know, you go back to the height of the lockdown, close to 1,000 people a day were dying in tragic circumstances. There was a lot more fear of infection because the infection rates in the community weren't as well understood. You know, they're a lot lower now than they were then. And I suspect what's happened is that people are starting to relax. And I don't know whether it's just because I'm a cautious person, but I wonder whether maybe we are relaxing a little bit too quickly. So if we were to criticize the guideline, we have to put the guideline in the context of the time it was written. But we also have to understand that we still have far, far more questions than we have answers. You know, we don't know what the risks are to the couple. You know, we suspect there may be some risks in pregnancy, but certainly even the RCOG aren't 100% clear on that. The Americans seem to take a slightly more cautious view there and suggest that there may be complications associated with pregnancy, etc., to a greater degree than we do. In terms of risks to staff as well, you know, what are the risks to staff? Well, I would suggest that a lot of our staff actually aren't terribly high risk. Some of them will be, but I guess the risk to the patient from staff being infected isn't necessarily a risk of the staff infecting them, because proper PPE use should really mitigate that risk. It's the risk of large numbers of staff going off at the same time and isolating, and then a centre being incapable of running. And that really is a very big risk, and we want to ensure that we are resilient against that risk. And so having a testing strategy for staff who present with any symptoms, or patients coming in just from a triage perspective, probably remains a good idea at this time. Should we be testing all patients when current community transmission rates appear to be relatively low? They weren't that low when the initial policy was written. They are low now. Have I seen in my clinic any positive results from those who've been screened? No. You know, I'm in rural Shropshire. I wouldn't expect to see a positive for a long while. But what we don't really understand, I guess, is whilst we understand the number of people that are testing positive in the population and the community, there are still some question marks around asymptomatics, etc., and around the true rate of background infection. Is it a good use of resources? I think is a very good question. In my particular NHS setting, we're not overutilizing resources at the moment. They have ramped up capacity for testing enormously, and you know, we can get tests very, very easily for our patients, and we're encouraged to do so. I think there's a big question around, I said this earlier, false negative rates for antigen and antibody testing. The antigen test, you know, you can get up to 30% false negative rate, is my understanding. So the argument could be, well, what's the point in doing it if a third of your patients almost are actually positive but are testing negative? And then again, with the antibody testing, there are 2 points here. One is that it would appear that some people who have a mild infection have an antibody response that goes down to undetectable levels relatively quickly. And there is also an inherent false negative rate for the antibody test as well. So how do you design a system that's foolproof, I think, is one of the questions that we have. And I think that the simple answer is that you can't, but you can mitigate risks to as great a degree as possible. And then obviously, we talked about the antibody test. what is the point in an antibody test in our setting? All it tells you is that somebody's been infected. It doesn't necessarily guarantee that they can't be reinfected. And it doesn't even guarantee that they're not still infectious. You know, they may have mounted an antibody response, but it may have been ineffective, and they may still have virus in their system. So there are so many questions, I would argue, that we probably should continue with a testing strategy for the time being. So, you know, in summary, we know very little, and that's a difficult thing to admit sometimes, particularly for people who, you know, medical and scientific professionals. We definitely need to build resilience. We really don't know if there's going to be a second wave or not, but it would be an absolute tragedy if the sector closed down again, if there was a second wave. So we've learned a lot from the first wave. I genuinely think that we can be resilient enough to sustain treatments through a second wave, but that's key to us continuing to offer treatment to patients. I think it's justified, as I said, to test patients and staff at this time. The when, how, and where do we perform these tests? Well, at the moment, we've got a guideline that will follow. That guideline will adapt. And I think what that guideline will adapt to primarily is probably changes to testing strategies as they develop, and also changes to national guidelines. So the ground is still moving beneath our feet, just a little bit more slowly than it was in March and April, but we need to adapt. That's the key. And I think with that, I'll finish. Thank you.
So our next speaker is Dr. Ippokratis Sarris, and he is Director in Reproductive Medicine at King's Fertility, where he's also the person responsible. And he's an honorary senior lecturer over at King's College Hospital.
Thank you very much. And obviously this is the long title of what we're talking about, but for me, very simply, it is really all about this. Very simple. To test or not to test? And that really is the question. And why is that relevant? Well, I think we should differentiate between you know, what is a legal requirement, which is a must, and we know that it's in the code of practice from the HFEA and actually enshrined in law, and what we should do, which is the best practice. And also guidelines, which are very useful, also set what is a minimal practice and also what is the best practice as well. So it's a very big range, and as we saw from Jason's presentation, there are different options, and I think it's very important to sort of look through that, because I'm interested in what's happening in the real world and real life, and I've had a lot of discussions with a lot of fellow PRs, and it's interesting some of the strategies that I've seen. Now, why is it so important to get it right? Well, of course, we heard from Jason, but I entirely agree, but I'll take it one step further, because to be perfectly honest, the way that I saw it is that fertility sector was one of the first non-COVID, non-cancer, non-emergency medical fields to reopen, both in the NHS and in the independent sector. And by and large, probably one of the first sectors that were closed during the pandemic to reopen. And of course, we don't want to have to stop again because of a second peak. And I really truly believe that we can become almost a test case as an example of how to do it right, and how we started quite early on, and hopefully how not to do it wrong. And of course, what we don't want is we don't want to be making bad headlines because of bad practice. And obviously, every time I see a story like this, it really makes me quite upset, because obviously being part of this field, I don't want to be seen that we're promoting any practice which is not considered appropriate. Now, very, very brief. As we know, it was a very, very quick sequence of events. On the 14th of March, ESHRE and ASRM came out with their guideline to say that we need to sort of try to stop fertility and getting people pregnant. And then the BFS and RCS came out 2 days later with a first sort of letter, and then on the 18th of March recommended the cessation of treatment, and the UK lockdown happened on the 20th of March, and then the HFEA came with its directive to say that we should stop all, well, I'll call it non-emergency, non-oncology fertility treatments. And then obviously, pretty much almost a month later, ESHRE said, actually now it's maybe the time to restart. On the 1st of May, Secretary of State Matt Hancock said that fertility will reopen very soon. And on the 10th of May, our Prime Minister said that the country is reopening. And in all fairness, there's a lot of criticism and a lot of sort of, discussion as to how much detail was given. But thankfully, the BFS and the RCS on the 6th of May came up with the guidelines that Jason has very nicely presented. On the 11th of May, the HFEA allowed clinics to apply to restart using their 50-question self-assessment questionnaire, which was a framework to help people to understand what they have to do. And as an example, on that same day, so my clinic, we applied to reopen, and just a day later, the HFEA granted that sort of approval. What is interesting is HFEA put us on the list, and literally within minutes, our patients have picked up on it. Actually, we found out from our patients that we'd been granted before even I got the email as PR from the HFEA. That was how quick it was. And of course, that puts all the pressure that you have to sort of meet those expectations. And we talked about the risk. And I'm not going to go into detail because I know that this is being recorded, so you can go back and look at the slides. But of course, there's the risk to the patients, to the staff, but also to the clinic. A lot of clinics, as we know in the UK, not just NHS, they're also independent sector, so they have also the financial pressure that we have to look at, especially if your capacity goes down and we're looking about people's jobs and livelihood as well, let alone the patient, which is very important as well. This, you're not meant to read this, it's just to show you all the documents that we had to prepare in order to be able to reopen. So clearly a lot of work have happened, and I'm sure that pretty much all clinics have done the same. But why is it important? Why are we making all this effort? We very nicely heard from Jason, risk. Well, we talked about risk in pregnancy. Thankfully, the RCOG, the Royal College of Obstetricians and Gynecologists, is regularly being looking at this. And in all fairness, the overall risk is probably quite low. And that would be fair to say. And then we're thinking about how about the risk of gametes and patients and us unwittingly having patients treated with COVID. And when it comes down to sort of if we can find the virus in gametes and seminal fluid, well, actually the evidence is not very clear and there's very little data. So there's a lot of questions, as Jason said, that we do not know. What is interesting here is also to figure out where we are in the world. So you can see here a little bit the total death rate from COVID-19. This is corrected for population, so it's per million. And you can see that unfortunately, we haven't fared very well compared to our neighbors. And you can see the heat map as well. We're pretty dark there as well. What's more relevant is the now. And the now is what's happening and how many new cases, again, corrected population we have. And as you can see, again, from the graphs, pretty much everywhere seems to be getting a little peak. And even here, the UK, we're going up. You can see what's happening in all sorts of places. So, I know that Jason said, this was happening back then, but the back then was here. And we're here now. So we're actually going up, we're not going down. And that is something that we shouldn't sort of dismiss. People say, oh, it's the testing. We do more tests, we find more cases. Well, actually, to be perfectly honest, when you look at the number of cases that are done in order to pick up a case, it's a very sort of good example as to how many people you're testing. Are you testing everybody, or are you just testing those you suspect to have the virus? And you can see, again, there's a very, very big variation. And actually, we're pretty much down here. We don't do that many tests for every case that we pick up. I mean, the reason why I've got the outlier here, which is New Zealand, is because they pretty much tested the entire population. So that, of course, will mean that you will do a lot of tests for the number of cases that you pick up. Most importantly, though, the UK is a big place and not everywhere is the same. And clearly, you have to know your own population. And as Jason said, where he is, maybe there's not that many cases, but I am actually based in London in the UK. And we're actually right in the middle of a very, very busy sort of borough. And actually, King's College Hospital was one of the first hospitals, not the first hospital, where cases of COVID-19 were found to be in the general hospital population, so nosocomial infections, rather than people just bring them in. So that really sort of meant that we're at the epicenter of what's happening. Maybe my opinion about things is slightly clouded by that. Now, we heard about the ESHRE strategy, so I'm not going to go into it. It's exactly what will be presented by Jason, just a little bit sort of more colorful there. And of course, we know about the questionnaire. And again, this is pretty much everything that has been discussed. So I'm not going to go into details about it. And the PCR testing, which is exactly what Jason mentioned about doing 2 tests. And this is pretty much what we started doing and what the guidelines stated. However, this is the interesting thing. So I thought that was the right thing, but pretty much very, very quickly, clinics that started doing PCR testing started getting bad publicity. They were criticized for doing 2 tests per treatment. They were criticized for doing tests at all. And they were criticized for not diverting patients to the free NHS test. This is obviously talking about those having private treatment in the independent sector. But as far as I can read it, and thank you very much, Jason, for mentioning it, actually doing 2 tests per treatment per person is actually what the guideline says. And of course, you don't have to do tests. Again, the guideline says that. But again, there is a difference between minimal practice and best practice. And again, that's a discussion to be had. And although we say that the NHS does free tests, to be perfectly honest, a lot of those tests, unless you're in an NHS trust, are done by post. So where's the witnessing which is required? But even so, it's not actually offered for asymptomatic patients, which are what we're meant to be screening in the first place, because if you're symptomatic, you don't even proceed. And there is also the ethical question: should the NHS be picking up the bill for people having private treatment? So, there's a lot of questions. And to be perfectly honest, the NHS and the independent sectors are testing everybody who's having elective operations. So not testing at all will be contrary to what everybody else is doing for every other treatment now. But what happened, as I was talking to a lot of my fellow PRs, this sort of bad publicity started pushing clinics to actually cut down on the testing and maybe starting using no tests and just the triage, which again is, part of the guidelines that they can do that as well. So it's interesting what effect this sort of publicity had. Now, we know about the staff and the code of conduct and about doing the antibodies, and all that has been described by Jason. But a little bit detail about all these tests. What is important is that the reason why there's such a problematic test is because coronavirus is an RNA virus, which actually is not a very, very good material to work with. So it's much more difficult to be able to pick up, which is why the detection rate is actually quite poor when it comes down to false positives. And again, when you actually test is very important. Actually, the best pickup rate is when you are asymptomatic, so not for asymptomatic people. So the value of doing PCR tests in asymptomatic people is actually debatable. And let's talk about serology. Actually, you start seeing antibodies rising pretty much straight away, but it takes quite a long time to be able to be picked up. And the other very specific IgG antibodies, they're not in themselves diagnostic as to where you are in your disease. So there's lots of antibodies. There's IgA, IgM, which probably is early infection, and then IgG, which will show later infectivity. And the different antibodies you can test. And I'm not going to go into the details of all the tests. They're very interesting, but again, very esoteric. And this is just to illustrate that there's a huge overlap between all these tests being positive and negative. So one snapshot of one test on its own is not enough to tell you you're immune or you're post-infection or where in the infection you are. And very, very quickly, I just want to mention, because I find this fascinating, we're talking about antibodies, and this is what we talk about immunity. That's when you see an infection coming and your body mounts this response, which then has memory. So when the infection comes back in, it will detect it before it comes, and it will hopefully you won't get infected. But it seems that the antibody response that the virus mounts is actually not necessarily very effective, and it seems to be waning quite quickly. So then this concept of a different type of immunity called T-cell immunity, which actually is a separate part of the immune system, which again has a very long-term memory, but it works in a very different way. It's very difficult to test. It's tested more in scientific sort of settings rather than a routine clinical setting. So again, there's so many questions, and this is fascinating. And again, I can answer as many questions as you want, but I'm just going to continue with what I want to say, which is the following. We really need a level playing field. And I think it's important sort of to really, I'm very sort of passionate about that, because the regulators rightly have specified that it's not a must, but there's a should. And the should is you should follow the professional guidance. I think that's correct and well done for that. And the professional guidelines actually have given a minimum and what I consider is a best standard of practice. And again, that is correct because it gives a range for people to be able to see where they fit in depending on where in the country and where they're in the pandemic. So again, not having rigid rules or correct. So I'm absolutely happy with that and well done, I think, to both organizations. However, what should clinics do? And I think the problem is we'll keep on debating and some clinics will say you just need questionnaires, others say you need testing or something in between. And I think the debate will keep on going. I really think though, that the sort of attitude of sort of see no evil, hear no evil, speak no evil when it comes down to testing is important. I had a very interesting discussion with a fellow PR. I'm not going to say who it was or where it was all confidential. We're talking about testing. I said, are you going to be testing? He said, no. I said, why is that? He goes, well, you know, what are you going to do if you test somebody, they have an embryo which is positive and we have to put in a tank and so we're debating it scientifically. And his answer was, I'd rather just not know because then I don't have to answer these questions, which is, you know, a valid point, but is that the correct one? But it's allowed, it's correct according to the regulator, which is according to the guidelines as well, and potentially according to where you are in that curve in the pandemic. But I think really, I'm going to leave you with one question and one question alone. If you, your partner, or your sister was having IVF, or any relative or friend, would you A, want them or yourself to be tested, or B, don't want yourself or them to be tested? And again, just think what you're going to do when you go on holidays, when you're taking that plane and you go to that crowded beach. What would you actually want those people to have undergone before they reach there? And with that in mind, I want to say that this is our Christmas party in 2019, 2020. And you can see we're all very happy. But unfortunately, we all have to live with this new pandemic and things have changed. So I don't know if I've answered any questions or given more questions myself, but thank you very much.
We've got a range of questions in. Perhaps I'll go with the most provocative one first, and you probably won't want to answer it. Jason, is Helen Clark wants to know, what will the new ARCS BFS guidelines recommend in terms of patient testing? Don't we all want to know that one? So
that's a great question, and if I had a crystal ball, I could tell you. But we haven't met yet. We haven't debated the issue yet, and we're meeting in a few weeks' time when I'm certain the entire situation will have changed. So I'll let you know as soon as I know, Helen, would be the answer there.
Great. Is there anything you want to chip in there, Ippokratis, or are you happy to let Jason take that one?
For that, what will be in the, well, I'm not part of the guidance group, but I think what I would like to know is, I think currently the guidance, I think it's all great work and I'm very happy with that, but I think the guidance very much now is either do triage, or if you're going to do testing, you have to do 2 tests. And I don't know if there's, what I've seen from people in the country, but also from different countries as well, what they're doing is almost getting a halfway approach where you have a little bit of triaging and maybe 1 test. And I don't know if there's a halfway house, because currently what a lot of people do doesn't follow any guidance as from what I can see, and it's somewhere in between. And you know, if we're talking about risk assessment and flexibility locally, maybe there's room for that. But again, that's just a suggestion, not part of the guidance group. And I think having options and not being absolutely rigid is good. And I think that's what the guidance has given so far.
Okay, so I'm going to take another question. I think if you go first with this one, Ippokratis, and then Jason can chip in. So this is from Veronique Berman. And she asks, you know, who will or who should, I suppose, cover the cost of patient testing?
Well, that is interesting, and also depends on what clinic you're in. I think when it comes down to NHS-funded patients, I think obviously it's appropriate for the funding body, the NHS, to pay for the test. If it comes down to self-funded test, and I'm not talking if this is an independent clinic or an NHS clinic, that's a different thing. Then the question is, of course, who should pick up the bill? And you know, you can argue that maybe if you're having private treatment, you should pay for the private treatment. Of course, if a clinic charges a lot of money, you can argue that they can actually absorb the cost, but not everybody does that. So again, you can't have a blanket rule. I think having a cost approach, this is what it costs, this is what we pass on, is one way. I think making profit in it as a clinic is probably not right. I'm not going to go about costings and all the rest, and that clipping from, that's a different discussion. I think if you can have tests which are done appropriately and witnessed, by the government, I think there is an argument for that as well. But I think it's the same sort of circular argument of who pays for fertility treatment. So I think you either sit on one end of the argument and the other end. How about viral screening? Can the GP do it if you're having it privately? Then you can go, well, I can only do it privately because the NHS doesn't afford it. And it goes round and around. So I think there's no right or wrong answer. It's where you sit with that particular argument. I think not profiteering is important, but that's a different discussion altogether throughout all fertility treatments.
Yes, I agree. Jason, did you want to chip in?
Yeah, I think Ippo has summarised it really well, but I also think that the situation here is that we're in a situation where a lot of people do not get NHS funded treatment, and they have no choice but to go private. I do think that centres should not profiteer. I think there's an argument to be made that you should pass this test on at cost if you have to charge for it. And I would suggest it's not unreasonable in some centres, in some settings. So in our setting, for example, our private patients don't pay because we have NHS testing available, and our trust is agreeable to that. But again, it goes back to this, what Ippo was saying earlier, around the sheer variation in practice around the country, and the sheer variation in availability of testing around the country is huge. So everybody has to make their own solution.
Yeah, and it also comes back to something which is very close to my heart, is that it's a postcode lottery approach to funding of IVF treatment, but we see that it cuts across many sectors of healthcare as well. So I want to move on to the next question now, which is from Rebecca Cowie. We'll start with you this time, Jason. If you only have one opportunity to test routinely in a treatment cycle, when is most likely to be beneficial?
If I only had one opportunity, I would do it just before the actual egg collection. That would be my time if I had just one test available. And
do you agree with that?
Actually, I don't, and this is probably, and I'll tell you why. I think you should start before you start the medication, because and this is my concept about it, if you believe that just triaging by questionnaire is enough, then if you want to have that second layer where you do the test, and then if it's negative, you continue, and only you retest if you're having any symptoms or any worries, then that means that if you are testing positive because you're using antigen testing, it is before you start medication. I think it's quite unfair to put a couple through an entire series of 10 days or 11 days or whatever of medication, get them ready, and then you just find out, you know what, you're the asymptomatic person that we could have picked up before. So personally, I feel initially is your baseline, and then you go, right, unless you have any sort of symptoms, which you have to be retested or whatever, then you can go ahead. And that fits with the no testing, you can just go ahead, or the double testing. I think the double testing concept is not a bad one, because of course we know it's such a bad test. I mean, not a bad test in itself, it's just not a very accurate test. But if you had to go for one, personally, that's where I disagree. I would go before you start the cycle, rather than, oh, you're positive, oh, sorry about this 10 days of injections or 12 or whatever.
Okay, I'm going to now try and mash up a couple of questions because we don't have a huge amount of time. So there's one question from Claire Wilson, which is, are males with no sign of COVID prior to semen analysis, should they be tested? I think is a question that she has. And then Annie Kant has one saying, should both the patient and the partner both be tested if testing is being undertaken? So do you want to go first this time, Ippokratis, and then we'll pass over to Jason?
I'll ask them both for both. So I think my feeling is that anybody who's providing gametes should be tested. And because that is what goes into the lab, that's what's going to create the embryo, and there's the rest. So I think you should test both partners. One argument is, well, if you're doing a frozen embryo transfer, do you have to test the male or not? I think the answer is, we're not providing gametes, so you don't have to. Then the circular argument is, they live in the same household, but then you can go for anybody in the same household. So I think you have to be sensible at some point. You're not going to test the entire household. But I think the principle, whoever is either receiving or giving the gamete should be tested. So yes to the two. When it comes down to semen analysis, I presume we're not talking about treatment samples, because I just said yes to that, but we're talking about diagnostic. And if that's the case, and I think the answer is no. First of all, most andrology labs are separate. You should have infection control policies anyway, because we don't test routinely for HIV, Hep B, C, and all the other viruses before we do our diagnostic semen analysis. We don't keep the sample, you throw it away. So as long as you have good infection control policies, and you've got your trios as well, and you're not using it for treatment, then I don't feel that you need to test the same way you don't test a woman that just comes for a consultation, just comes for a scan, or just comes for a blood test. So I think I've answered both of those.
Thank you. Jason, do you want to?
Yes, I'd agree with the principle that if you're a gamete provider for treatment, then you should be tested. So both the male and female partner should be tested. The issue around frozen embryo transfers, again, I'm being very agreeable tonight, but I agree with Ippokratis. I think he's right there. In terms of, if we're talking about diagnostic semen analysis, we have to remember that the risk of infection through semen is unproven. You know, there's mixed messages in the literature there about that. And also, if you're wearing PPE and you're analysing the sample as you should in the right conditions, then you shouldn't really be at risk of cross-infection to any greater degree than you would be for anything else that people aren't screened for when they're having a diagnostic test.
Okay, so we're running a little bit short on time now, so I'm going to go with the most popular question that we have left, which is from Tim Child. So he says, when there's a second wave and it's considered that clinics should close again, perhaps the decision needs to be on a clinic-by-clinic basis. It seems to me that clinics based in NHS hospitals had greater issues with losing their NHS staff to other parts of the hospital. This isn't necessarily the case in the independent sector, and he'd like both of your comments on that. So Jason, do you want to start on that one?
Yeah, I think key to what we need to do as a sector now is to prevent that from happening. You know, it was a tragedy that happened in the first place. It was necessary, sadly, but I think now, following the policies that we've got and with the level of testing that we've got and the protocols we have in place, we should be resilient enough to prevent that from happening nationally. On a local level, it becomes quite different though. So we may be looking at local regional shutdowns at some stage, and that I imagine if it's a full lockdown, it might affect a local NHS centre to a greater degree than it would a private centre. But staffing aside, I would suggest that both NHS and private centres, all being equal, should be able to stay open.
And Ippokratis, you seem to be nodding.
I mean, I don't know if I want to make a prediction. I don't think, unless something really, really bad happens, I don't think that we're going to close again. I don't think the entire country will close again. I think it will be more sort of patchy and regional and so on and so forth. So hopefully that's not going to happen. And I think the other thing that's happened, which is very different from March, is that we know a lot more about not just the virus and how to treat, but also how to handle it. So even NHS hospitals are actually now looking at sort of, COVID light or green pathways and COVID sort of, heavy, and hospitals potentially being COVID and non-COVID. So I think even in the NHS, we'll be able, I hope anyway, to some extent, we'll be able to continue with some elective fertility being sort of somewhere in between treatments, even if there's a second peak, unless we're talking about a really big catastrophe. And if you take that a step further, then of course, then there's no reason why, even if some NHS sites cannot start, because let's say they're COVID red or heavy and they're not COVID green, then the independent sector should be able to continue as long as it just has the same sort of kind of framework of being COVID light, COVID green, whatever you want to call it. So I think it will be very much patchy. I do not think that we're going to have this sort of blanket everybody, the entire country is stopping for many economic reasons, and I'm stopping there because I think
no, that's my fingers crossed again. Sorry, it wasn't me.
All right, I thought it was like, okay, enough said. Sorry, apologies.
No, that was my fingers crossed. I'm obviously like everyone hoping that there isn't going to be a second wave or second peak, and I think it is really crucial, having seen the impact that it had, on patients, and it was at a time of great uncertainty for everybody in society, but the impact that had on patients, obviously anything that fertility clinics can do with support from the professional bodies and support from the HFEA to build in resilience and to keep open, and to demonstrate that they have been really, preparing and refining. I think that is it, and I think that for me is one of the key things with the guidance that we've had and that you've supported it, Ippokratis, is that having that flexibility to enable, whether it is you need a sort of a really sort of draconian approach because of your local community, or whether a lighter touch is more appropriate. I think that there is some merit in that.